Hello, and thank you for joining us. We're going to go ahead and get started in just a couple minutes here. Just for those of you who have dialed in, just a reminder that the audio for the webinar will be streaming through your computer speakers. We do have a phone number if you're having any difficulty with that, and you can see that on the screen. Great, thank you all for joining us today. This is the Q-Centrix CMS 2017 Proposed Rule Summary and the Impact of those Proposed Rules webinar. My name is Kathy Phelps, and I'm the Director of Marketing at Q-Centrix. I'm going to give you a couple of just quick notes about the webinar, and then we'll go ahead and get started with our featured speakers. First note, on your screen, on the lower part of your screen, you'll see a chat function. If you have any questions throughout the webinar, please feel free to just submit those through the chat function, and we'll answer them at the end of the webinar. We did allot plenty of time at the end for questions and answers, so please feel free to submit anything throughout the webinar. Also, we've recorded the webinar, so it will be available on our website, q-centrix.com, Q-Centrix. And that should be available in 48 hours for download. Last but not least, the deck itself, along with some notes, will be available for attendees as well. Without further ado, I'm going to tell you a little bit about Q-Centrix, just so that you know how we came about the information that we're going to be presenting to you today. So at the top of the screen, you'll see our mission is to help healthcare providers measurably improve the safety and quality of care they deliver while reducing costs through the comprehensive management of quality data. We always offer our mission because more often than not, our mission very well aligns with that of our partners. So you probably see a lot of commonalities there. What we do here, we do three things. We try to improve the quality and safety of patient care. We typically lower the cost for our partners, and we typically optimize their resources or help them optimize their resource, and what many of you may come to know as allowing them to have their team work at the top of their license. How do we do that? We have more than 600 quality information specialists that work remotely, that partner with hospitals throughout the country. Right now we have more than 300 partners throughout the country, and we currently abstract we have more than 1.5 million quality data transactions a year. And you know, whenever you're working at that scale, we've got a lot of efficiencies, so that's one of the ways that we certainly help our partner hospitals. So that's a little bit about us. Of course, if you have any questions about us, feel free to reach out through that chat function as well. But I'm going to go ahead and tell you a little bit about our featured speakers today. So this webinar, our first featured speaker is Jennifer Haas, and Jen has been with Q-Centrix since 2011. She primarily reviews CMS rules and trains our team, so that team of 600 quality information specialists, on any of the impacts of those proposed and then finalized rules. And then prior to Q-Centrix, she worked at Iowa Foundation for Medical Care as the lead clinician and quality assurance reviewer for several core measures, the quality assurance reviewer on Quality Net Quest and CDAC and CART. Previously, she worked for Mercy Hospital as a CCU clinical nurse, and she received her Bachelor of Science in Biology from Iowa State and her nursing degree from Mercy College of Health Sciences. We'll hear from Jen first, and then after Jen, we'll hear from Brian Foy, who's our Vice President of Product Development here at Q-Centrix. Brian spent most of his career with strategic accountability for software applications in the HIT space. He worked at TransUnion and later at Altegra Health, leading healthcare analytics applications through an acquisition while overseeing the addition of key quality reporting and care management features. At Blue Cross Blue Shield of Illinois, Foy oversaw the implementation of a care and condition management reporting system, which fulfilled a key gap in the company's care management product offering. Among his many industry memberships, Foy sits on the NQS Admission and Readmission Standing Committee, and he has an MA in Health Services Administration from Xavier University and a BA in Economics from Ohio University. Without further ado, I'm going to hand it over to Jennifer Haas. Jen?
Hello, good afternoon, everybody. So today I would like to start out and talk with you about the chart abstracted measures portion of the proposed rules. So the first part is the removed measures for the inpatient quality reporting program. These proposals are the ones that impact discharges beginning with January 2017 and are for the fiscal year 2019 payment determination and then the subsequent years. CMS again used their adopted criteria for determining a topped-out status of the hospital IQR program measures, and that is 1, a statistically indistinguishable performance at the 75th and 90th percentiles, and 2, a truncated coefficient of variation of less than or equal to 1/10. And so the two measures that are proposed to be removed are stroke 4, the thrombolytic therapy, and VTE 5, venous thromboembolism discharge instructions. It was determined that both of these measures met the criteria and that the burdens of retaining these measures outweighed the benefits, and so therefore they were proposed to remove them in their chart abstraction form for the fiscal year 2019 payment determination. So for the inpatient quality reporting program, that leaves us with 6 chart abstracted measures. They're listed here on the slide. The asterisks indicate the measures that are both chart abstracted and then eCQM eligible. So ED1, that's our median time from ED arrival to ED departure for admitted ED patients. ED2, the admit decision time to ED departure time for admitted patients. And PCO1, the elective delivery, which is collected in aggregate and submitted via the web-based tool, or these 3 can be either electronically submitted as an eCQM and also as the chart abstracted. And then the additional 3 required are the sepsis 1, severe sepsis and septic shock management bundle, and VTE 6, the incidence of potentially preventable VTE thromboembolism, and IMM 2, which is our influenza immunization measure. So the continued requirements for the IQR reporting program is for the fiscal year 2019 and subsequent years is the chart abstracted versions of ED1, ED2, PCO1, and VTE 6 remain the same as they were previously finalized. So that means the hospitals must submit a full calendar year of data, which would cover quarters 1, 2, 3, and 4, via the chart abstraction, regardless of whether the data is also submitted electronically in accordance with the applicable submission requirements. Now for the inpatient psych facility quality reporting program, CMS has proposed to actually add a measure. And for this, this will be the fiscal year 2019 as well, and we'll start with the January 2017 discharges. What they are proposing to add is the sub-3 alcohol and other drug use disorder treatment provided or offered at discharge measure, and then the subset measure, sub-3A, alcohol and other drug use disorder treatment at discharge. And then this will be the remaining measures. Nothing is changing with these. These should all be effective for the current 2016 discharges for the inpatient psych facility reporting program. So we've got a whole bunch of them here. The HBIPs, we've had a couple retire, and then we had a couple added for 2016. So I'll just go through these and list them out for those of you that aren't able to see the screen. We have HBIPs 1, and that is your admission screening, and that is actually only required for joint commission submission. So if you're an ORIX, you chose HBIPs as one of your ORIX 6, then you would do that. If it's only for the CMS program requirements, that is not required. Then we have HBIPs 2 and 3, which are events. We've got the restraints and seclusions there. And then we have HBIPs 5, and that is the patient's discharge on multiple antipsychotic medications with the appropriate justification. So then we move into the substance measures. So those would be sub 1, which is the alcohol use screening, sub 2, and its subset 2A, which is the alcohol use brief intervention provided or offered, and the subset measure, which is just alcohol use brief intervention. Sub 3 and 3A, and that is the alcohol and other drug use disorder treatment provided or offered at discharge, and then alcohol and other use disorder treatment at discharge. Then we go into the tobacco measures. Tobacco 1 is the tobacco use screening. Tobacco 2 is the tobacco use treatment provided or offered at discharge, and then the tobacco use treatment provided. Tobacco 3 and 3A, tobacco use treatment provided or offered at discharge, and then the tobacco use treatment at discharge. Then we've got IMM 2, which is the influenza immunization, and that is the same that is required for the inpatient reporting program. Then now with this is actually the 3 measures that are coming up with July discharges. So we haven't actually started abstraction of these, but they are part of what we're abstracting with 2016 discharges. And the first one is the transition record with specified elements received by discharged patients, and that's discharges from an inpatient facility to home or self-care or any other site of care. And then we have the timely transmission of transition record, so discharges from an inpatient facility to home, self-care, or any other site of care as well. And then the third new one that will be starting with July discharges is the screening for metabolic disorders. Okay, well, I will turn it over to Brian, and he will start out with talking about the electronically submitted measures.
Hello, everyone. This is Brian Foy. Thanks for joining us this morning or this afternoon, wherever you are in the country. I'm going to speak to you about the changes that have been proposed by CMS for the electronically submitted measures. Then I'll spend a little bit of time on some of the changes that have been proposed for value-based purchasing. Jen will do a quick recap on the key points to remember, and then we'd like to share some of our anecdotal observations with where we see things headed based on our interactions this year thus far with CMS, with the National Quality Forum, and Joint Commission and others. But for now, let's talk about the proposed changes to electronically submitted measures. First of all, as many of you know, or may know, several measures have been proposed for removal. CMS is proposing the removal of these eCQM measures for the fiscal year 2019 payment determination. And remember, when you're reading the regulations, the CMS will speak about time periods in 2 different ways. There's the payment determination year, which lags the actual submission years. So for fiscal year 2019 payment determination is based upon discharges in calendar year 2017. And so those two time periods are synonymous. I believe throughout the rest of our presentation we talk about calendar year 2017, but please keep that in mind. The fiscal year typically has an 18-month or 2-year lag on the actual performance year. We'll get into a little more about why and what may have been the reasoning behind these removals, but for now this is the list. I'm going to walk through this really quickly, and then there are basically 3 different criteria for removing a measure. So the measures that have been removed for the benefit of those of you who are only listening, it's AMI 2, AMI 7A, AMI 10, a hypertension measure, pneumonia 6. There are then 3 skip infection measures, 1A, 2A, and 9. 1 stroke measure, it's stroke 4. And 4 VTE measures have been submitted for removal, and that's 3, 4, 5, and 6. Now, there are basically 3 criteria that the CMS identified as rationale for removing these measures, and I'm just going to list them off now. In previous sessions, we've gotten questions about the rationale for leaving a chart-abstracted version of a measure but removing an electronic version, and so hopefully this will give you some insight into the thinking at CMS. So there are 3 reasons, and those 3 reasons for removing an eCQM are, number 1, that it was topped out, the performance has been topped out. Number 2, that performance or improvement does not result in better patient outcomes, so it's effectively irrelevant for patient outcomes. And then the 3rd reason they cite is that the measure is no longer feasible to implement the measure specifications. And that's what we heard a lot in our dealings with the market thus far this year. There have been significant challenges with implementation of many measures, and we'll drill down on that a little bit more later in the presentation. Okay. As you know, 13 eCQMs, as we just reviewed, have been proposed for removal from both the IQR program and the Medicaid EHR incentive program that's more commonly referred to as meaningful use. We think the rationale here is for hospitals to be able to focus on a smaller, more specific subset of eCQMs and keeping programs aligned. We think they're also CMS is likely also positioning itself for growth in the number of required measures. So by removing 13 measures, and as you'll see in a moment, they can increase the number of required measures in 2017. And then by having a more focused and quote-unquote cleaner list of measures that need to be submitted, they can begin adding measures that are more appropriately designed for electronic submission. Again, we'll get into that in a moment. Obviously, the flip side of this coin is that there are several measures remaining. There are 15, in fact, remaining. And I will review those here again for you for the benefit of those of you who are just listening in. The remaining measures for eCQMs that hospitals will be, that are proposed to be required for submission in 2017 are AMI 8A, CAC3, 2 ED measures, ED1 and ED2. There's 2 PC measures, PC01 and PC5. There are several stroke measures, 2, 3, 5, 6, and 8, and 10. Those are stroke measures. And VTE 1 and 2 are also on the list of measures that can be submitted. And again, the asterisks, as they did when Jen was speaking, mean that there is a counterpart for that measure on the manual abstraction side. One thing I do want to point out is that even though the names are the same for, say, ED1 and ED2, there is a manual abstracted version of that. The specifications, as you all, I think, know, can vary quite widely. And so even though the names are the same, often the results can be quite different, and so can the mechanisms for actually collecting that data in your medical records. So those are the remaining measures. A couple of other changes are documented in the proposed rule that we want to review now. First of all, the number of required eCQMs, I think I just mentioned this, would increase as compared to that for calendar year 2016. It is increasing from 4 to 15 eCQMs. So effectively what we're talking about here is going from choosing 4 out of 28 measures to being required to submit all 15 remaining measures, presuming that those measures are relevant to your hospital's practices. The CMS is proposing a change to the reporting period as well. As you know, this year that you can choose either from the third quarter or the fourth quarter and submit that data by February 28th, 2017. Starting next year, for calendar year 2017, hospitals will be required to submit data for the entire calendar year. And then coincident with that change, there will be a 60-day lag between the end of the time period, which is December 31st, 2017, and the required submission time frame for the measures. Now, effectively, that's a little bit of a change to this year. As you know, you can choose, as I just said, third quarter or fourth quarter and submit by 2/28/17. And so if you chose the fourth quarter, that would effectively be a 60-day lag, as they're proposing now. But if you had chosen the third quarter, that would be more like a 150-day lag between the end of that reporting period and when you were required to submit. So they're standardizing on that 60-day time frame, and I should say they're proposing to standardize on that 60-day time frame for calendar year 2016. The other relevant piece of data here is the additions for the eCQMs. There are 2 additions currently that vendors could be certifying for eCQMs. There's the 2014 edition and the 2015 edition. For calendar year 2016, your certified electronic healthcare technology health record technology, can be certified for either 2014 or 2015. That holds for 2017. So the data that you submit to CMS for calendar year 2017 can be submitted using certified technology on either the 2014 or 2015 editions. Just think of these additions as minor specification changes to the measures themselves. Because of timing, they want the electronic health record vendors to have flexibility in preparing for submission on behalf of hospitals. Now for 2018, that changes. Starting in the spring of 2018, that's when your submission vendor must be certified to the 2015 edition. So effectively, those changes will go into place, get finalized this summer for the 2015 edition. The testing mechanisms will be updated by the industry, and then your vendors should be moving rapidly towards certification for the 2015 edition throughout calendar year 2017, or perhaps even earlier in the fourth quarter of this year. So that's what's going on with the changes to submission. Now there is one other thing that's called out in the rule that we wanted to spend some time on, and that is that it flat out reiterates that it is permissible to manually abstract from a non-certified system to a certified system with the intention of submitting to CMS. And so what they're acknowledging here is that there are probably a surprisingly large number of hospitals who have not attested to meaningful use 2, and they need to find other mechanisms for submitting this data to CMS. And so it is, as I said, permissible to take data from a non-certified system, manually abstract it into that certified system, and then submit. And just because I think this is kind of an important point, I'm just going to read to you the snippet from the regulation. And again, and I know this is probably pretty dense for the audio portion of the call here, but this will be documented in the speaker notes that we circulate to the group at the conclusion of the webinar. But here's the snippet that we're interpreting. Hospitals must submit eCQM data via the Quality Reporting Document Architecture, or QRDA. And that's just an allusion to the file format that your vendor must use to actually transmit data. It's called QRDA, and there are a couple of different categories of QRDA files, but that's just a file specification. In addition, hospitals may use third parties to submit these QRDA1 files on their behalf, and can either use abstraction or pull the data from non-certified sources in order to then input these data into CEHRT, and that's the acronym for Certified Electronic Health Record Technology, for capture and reporting QRDA1. In layman's terms, this is exactly what I just said it was. If you've got data resident in a non-certified system, that you need to leverage to report and meet your reporting obligations, you can extract or abstract manually that data into another system for submitting to CMS through QualityNet. Again, I realize this is really dense, and I'm sorry that you have to listen to this to process it, but we do have this information for you that you can consume in written form that will circulate at the conclusion of the call. Okay. Let's move on to the CMS validation results. Documented within the proposed rule this year is some commentary about a pilot that the CMS conducted last year for validating submission results from about 100 hospitals. And what they found was there was less than a 50% match between chart abstracted data and eCQM measures. And again, I'm going to read a little bit of documentation from the proposed rule. The results of the pilot test yielded measure record matching rates, that is, the rates of medical record abstracted values as compared to the values reported in the files, of less than 50% for all of the measures reported. The discrepancies, and I think this is actually promising, this next point, the discrepancies were mainly due to missing data rather than differences in reported versus abstracted values. And so what the CMS found in the data that they received is that primarily hospitals were not able to capture the data element for the eCQM in the appropriate place in the medical record and have that flow through accurately to the actual electronic file that they submitted to CMS. Finally, Stroke 4 and VTE1 were the best matching eCQMs, and they had matching element rates of manual abstraction versus electronic submission of 48%. So that's just sort of presented there without editorial. That's the results of the pilot. And so let's move on to something that yielded, I think, as a result of this pilot, which is a new validation process that the proposed regulation documents. The CMS is proposing to adopt a validation process for eCQM data submissions beginning in the spring of calendar year 2018. The validation process for eCQM is as follows. First of all, it will impact up to 200 hospitals. It will actually impact probably slightly less than 200 hospitals because there's some exclusion criteria. Once they sample the 200 hospitals, any hospital that's already been sampled for manual abstraction audits will be relieved of their obligation for the eCQM validation, and any hospital that is demonstrating a hardship of some kind through a hardship waiver will not be required to participate in the validation as well. The validation process works as follows. The hospital will select 32 cases from the submitted QRDA data that they receive, and the QRDA data that they're going to be running the pilot on, or excuse me, the validation on, is based on the individual patient-level data that they get. Hospitals will then submit patient-level medical record data for each of the 32 selected cases within 30 days of the record's request date. And in the body of the regulation, CMS justified the number of sampled cases, which is 32, based on some statistical analysis that they're using, basically stating that 32 records is an adequate number of records to sample to get a baseline percentage or a baseline validation that's meaningful for them from hospital to hospital. Okay, so there are a couple of points that we wanted to make based on this validation process. The validation process that they're proposing for eCQMs definitely differs than what you're probably more accustomed to if you've been audited by CMS for manually abstracted measures. For the eCQM validation, hospitals must submit 75% of the requested data in a timely manner, and the validation score, and this is the key part, the validation score will not impact payment determination. And again, that is the fundamental difference between this validation and the manual abstraction or the chart abstraction program. You do receive a reduction in payment if you do not meet a 75% validation score for chart abstracted measures. And so participating in this program is fairly straightforward at this point. If you get selected, first of all, you do not have to participate if you've already been selected for another audit for manual abstracted measures. Second of all, your obligation is only to return 75% of the records, the data for the records that were sampled within 30 days. Whatever they find in terms of their validation will not impact your payment determination, and that's only for the eCQM portion of the validation. We've got a snippet of text we've taken from the proposed rule that really breaks this down. They provide a couple of examples. I'm not going to read that to you now, but again, that's information that you'll find in the speaker notes that will be circulated at the conclusion of the call. Okay, we made it through eCQMs. So now we're going to spend maybe just 5 minutes on the changes to the value-based purchasing program, and then we'll move into our conclusion content. Okay, the first change we'd like to talk about is a simple change. They've changed the name of one of the domains. There are still 4 domains. They're proposing still to have 4 domains, and each domain is weighted at 25% equally. But they are changing the patient and caregiver-centered experience of care / care coordination domain name to person and community engagement beginning with fiscal year 2019. There's really no further color given for the rationale for that change, and so you all can read into that what you want about the measures that will make their way into that domain. This seems like a more explicitly population health domain, but that's the change for this year, person and community engagement. Okay, there are 2 new condition-specific payment measures for the fiscal year 2021 program year. First is an acute myocardial infarction measure. That's an AMI measure. It is hospital level, risk standardized, payment associated with a 30-day episode of care for AMI. So very similar to the other payment measures. Baseline period begins with fiscal year 2021 program year. It would be added to the efficiency and cost reduction domain, and the performance standards are calculated based on data from the performance period, not the baseline period. So performance will be after fiscal year 2021. The other payment measure is a heart failure measure, again, quite similar in structure to AMI and the other measures. Again, this is a hospital level, risk standardized, payment associated, 30-day episode of care measure for heart failure. Reiterating, the baseline period is the same as the other measure for fiscal year 2021. Same domain as the other measure, efficiency and cost reduction. They do give some detail that the reason for adding the measure is that it aligns with their strategy, their quality strategy goal of making care more affordable. And the performance standard, again, is calculated based on data from the performance period and not the baseline period. So they only begin collecting baselines in 2021 for these new measures. Okay. A couple more changes to value-based purchasing we wanted to make you aware of. There is a change to the 30-day mortality measure, or a 30-day mortality measure. It's a pneumonia measure. Again, this, just to jog your memories, this is again another 30-day all-cause, and it's following pneumonia hospitalization. The changes to this measure were substantive revisions to the measure cohort. Excuse me. Sorry, my voice is going here. I've been talking a lot today. So the changes to the cohort for this pneumonia mortality measure are as follows. Patients with a principal discharge diagnosis of pneumonia, and that's the current reported cohort. That's not a change. That was how it was crafted up until the change. The 2 new changes to the cohort are that patients with a principal discharge diagnosis of aspiration pneumonia will be added to the cohort, as well as patients with a principal discharge diagnosis of sepsis, not including severe sepsis. So your septic patients, principal diagnosis discharge of sepsis, with a secondary diagnosis of pneumonia coded as POA or present on admission will also be added to the cohort for this mortality measure. The non-updated cohort version of the measure will remain prior to 2021, and so the changes to this measure go in effect for the baseline period of 2020, for fiscal year 2021. So you're still required to measure that initial cohort for pneumonia, which is just principal discharge of PN. There are changes to ward locations in the CLABSI and CAUTI measures. I don't want to read through these. It's a little bit confusing. It's sort of presented in tabular format in the proposed rule. Again, these will find their way into your speaker notes. But I think to summarize, the number of wards where patients could have been pulled into the populations for these measures is increasing to some ICU locations and some med-surg wards for fiscal year 2019. Again, I'm sort of being mysterious about this. It's a little bit hard to just explain verbally, but again, there are some slight changes to the units within the hospital where you can find these patients for CAUTI and CLABSI for value-based purchasing, and those changes will find their way into your speaker notes. And finally, there are no proposed changes to the baseline or performance periods to the other measures within value-based purchasing. Okay, so those are our updates on eCQMs and value-based purchasing. I'm just going to hand it back over to Jen for maybe 2 minutes to recap the key components of our talk, and then she'll hand it back over to me for a final conclusion.
Great, thanks, Brian. Okay, so here's a quick summary of the items that we've talked about today from the proposed rules. So for the inpatient reporting program, we had a proposed removal of 2 of the chart abstracted measures, which would be stroke 4 and VTE 5. For the inpatient psychiatric reporting program, though, we actually had the addition of 1 chart abstracted measure proposed, and that would be the sub 3 measure and the subset of 3A. As far as the eCQMs go, there was a proposed increased number of required electronic measures from 4 up to 15, but with that, there were also 13 of them removed. And then the other part with that is that a full year of data is going to be required for submission versus just the 2 quarters. In addition is the validation of the eCQM measures that will begin next year. And then, another big point that we wanted to make was that the manual abstraction into a certified system to generate files is permissible with that program. And then as far as the eCQM pilot that went through, when we were comparing the match rate between the data submitted, from chart abstraction and, electronically, and then a chart audit, there was a match rate of less than 50%. So there's definitely some work to be done there to make sure that information is being captured correctly. So I will turn it back over to you, Brian.
Thanks, Jen. This is our last bit of prepared content, then we're going to do questions. So get ready to submit your questions. And one thing I want to make clear about this final bit of content is that these are our observations about what we see and where we see things headed. This is us editorializing now. This is not necessarily something that we've read in the regulation. So try and keep that straight as you take this information back to your teams and craft your strategies for the changes in the rule. But something that maybe is a little bit misleading with this proposed rule and where we see things going is this first point. The total number of eCQMs is on the rise. The CMS and the NQF, the National Quality Forum, were making a clear plea to the market and measure developments to increase the number of eCQMs. And what we think they maybe were a little bit misguided on in the early years of this program is that, and as you could see in the rationale that I described for the removal of some of those eCQMs, is that some of those measures were just not built for electronic measurement. They were not built to be implemented by a machine. They've admitted that on many of those measures, and they got those out of the mix. So they don't want hospitals, trying to implement something that's just they're not going to be successful at. So, the way we see it is they've sort of cut the fat from that program now. They want you to rapidly increase the number of measures that you're submitting from 4 to 15. That's a pretty large jump. And then they're making a plea to the third-party measurement development market to say we need more well-crafted eCQMs. And so our hypothesis is that you'll continue to see an influx of potential eCQMs to submit And ultimately, what we think you'll have is hundreds of measures that you'll choose from, and then a minimum requirement within each of the domains that you're required to submit as part of IPPS. So don't be misled by the reduction in measures. We think that's a pause, and those will increase rapidly. The other thing that will change, and this is maybe something to keep your eye on with your technology partners, is that testing and certification requirements will probably evolve over the next several years. CMS submitted a request for information to basically the public earlier this year, asking for feedback on how they should standardize reporting, or testing and certification processes for third-party vendors that submit electronic data to them. And what we think will happen is there will be a more regular required certification process, possibly annually, and the testing that Certified Electronic Health Record Technology, or CEHRT, goes through will slowly become more rigorous. And so that will impact your technology partners' abilities to continue to stay on top of what's happening. And so we encourage all of you to closely monitor how well your technology vendors are staying close to that process. Manual validation of eCQMs will absolutely continue, as you saw both in their validation pilot and in their strategy to keep a couple of manually abstracted measures. That's really the only way that they can ensure that what they're getting on the electronic side is actually accurate. And so we see the topping out, I should say, of chart abstracted measures will slow. We don't think that will go to zero anytime soon. And they will keep those around as long as they're still trying to get hospitals moved over to this electronic paradigm. So I wouldn't expect you to be completely relieved of your chart abstraction obligations in, say, the next 24 to 36 months. Registry participation is a biggie. In our business, we've seen tremendous growth in registry participation amongst our customers, and the CMS and ONC and others at National Quality Forum meetings have absolutely positioned their view of registries as a source of potential innovation. They want hospitals to continue participating in more registries. They want professional societies to take ownership of what they're experts at and form new registries. And so you should expect to see maybe continued legislation that alleviates some of your required reporting burdens to CMS, so long as you're reporting to a registry. It's an important way to evaluate physician performance. And again, it's something that hospitals oftentimes opt into and are more likely to innovate around versus the requirements for participating in a quality measurement program with CMS. And then the last thing we're seeing is just this focus on our industry, on the quality industry. We see more and more folks with quality backgrounds in strategic positions at hospitals when we talk to them. Many of the sessions at the National Quality Forum, particularly ones about changes to quality measurement, were standing room only. It's 7:30 in the morning, and there's standing room only availability at these sessions talking about what the CMS plans to do with the future of quality measurement. And so we continue to see quality measurement as a vital part of a hospital's operations. And so for those of you on the phone who have responsibilities for quality measurement, I think it's probably a high proportion of you. You'll continue to be a focus of innovation, of savings, of safety at your facilities, and that's what we see when we talk to third parties as well. And with that, we'll conclude our prepared content and move into the Q&A portion. Kathy?
Thanks, Brian. Just as a reminder, feel free to submit any of your questions through the chat function on the bottom of your screen. We're going to go ahead and get started with the questions that have been sent throughout the presentation. And one quick note, a lot of you have asked if the slides and the notes will be available. They will be available. We'll send you an email with all of the downloads within 48 hours. So you'll be able to rewatch this webinar, review the slides and the speaker notes on your own and with your team as well. First question that we have, I will direct this to you, Jen. Facilities that are certified stroke centers still have to abstract stroke 4, correct, for Joint Commission?
Yes, that is correct. Nothing has changed for the requirements for the certified stroke centers. This is just for the inpatient reporting program only.
Great. Second question, do you think, this is relative to the 50% match rate from the CMS Pilot, do you think it was due to mapping issues or workflow issues that the data was not captured electronically, or both? I'm going to direct that at you, Brian.
Well, that's an insightful question. They didn't really give any color as to sort of the provenance of the issue, but I think the encouraging thing is that it wasn't as though they found wrong data. It wasn't as though the software was screwing things up. It wasn't as though it was changing a value. It's that the data was never there to begin with and didn't find its way through to the file. And I will say, as many of the measures that were probably submitted to CMS, they didn't give any transparency as to the volume of measures that were submitted to them, which measures the hospital actually selected to submit. But my guess is that they tended to skew on the simple side, and they were probably measures that hospitals had been submitting through chart abstraction originally. And so, if you ask me to sort of hedge which reason I thought it was, I'd say it's a mapping issue. I'd say most hospitals are probably capturing that data, if not in a discrete field, in an unstructured format, in a physician note somewhere. It's in that medical record, and the technology is just not sophisticated enough yet to pull that unstructured data onto a file and then into a discrete format and actually calculate it. So I'll go out on the limb and say mapping, although just being transparent, I don't actually have the data that they used.
Sure, and I'll just kind of second that thought, Brian. From the abstraction clinical perspective, there are a lot of data elements or measures that are very open to interpretation and have information documented in multiple places. Like you said, it's buried in that physician note. It's hard for an electronic the system to pull that information. So I agree with your analysis of that.
Great. This question is related to the market observations. Which registries do you believe will rise to priority participation levels?
Oh, that's a really good question. I can tell you where we're seeing a lot of growth and sort of who we think the more sophisticated vendors are. For sure, the ACC and the NCDR registries are important registries. You can see CMS focusing on cardiovascular topics for measurement. We see a lot of growth in the AHA registries, like the guidelines. STS is an important registry. Trauma, cancer will always be important registries. We think. I believe cancer is one of the very few registries that's required at the state and federal level, if I'm not mistaken there. And then there's some more niche registries like vascular registries that we're seeing some growth in as well. I don't know if I've adequately answered your question, but where we sit, that's where we're seeing a lot of growth of participation. And those are the professional societies that wield the largest sort of presence to where they could possibly get, something written into a regulation, something written into a meaningful use reg where maybe there's some required development that an EMR vendor has to do to submit a cardiovascular registry. And again, you can get a hold of us after this call via email if you'd like to have maybe a deeper dive on those topics. We could get you in front of the right people, but that's my take on those registries. Jen, do you have anything to add?
No, I concur.
The follow-up question to this you may have answered in that the question is, which registries do you currently have business with? I think you pretty much...
I'll interpret that two ways. We have partnerships with several professional societies. We have a partnership with the American College of Cardiologists and their NCDR registries. We have a partnership with M2S. They do vascular registries. I believe we work with the AHA and they get with the guidelines registries. And so those are where we have actual partnerships. But if you're asking what our capabilities are, that's much broader. We abstract over 30 different registries. And so if you have some in mind, particularly niche or state-level registries that you'd like to learn more about, just go ahead and contact us. We can give you a whole list.
Right. I was going to say it's very seldom that we hear of a registry that we don't work with. And I would just add to the partners M2S. I think that was the last question that we received, but I'm going to go ahead and flash our contact information on the screen. And say that if any of you have any questions, please feel free to reach out using the info@Q-Centrix email. There's also a contact form on our website, and I will make sure if it comes in through the info@ email to get you in contact with any of our speakers, and it will be that email address that will be sending out the speaker notes, the slides, and the recorded video. You can also find the recorded webinar on our website. And I just want to thank everyone for participating today. Thanks. Have a great day.